Hi everyone, my name is Tom Hove. I am the training manager for VTSC. Um, for folks that are on here that are interested in getting continuing education credits for this training, we do ask that you please turn on your camera so we know that you are here and that you just haven't logged in and walked away from your computer. We understand that at times bandwidth might be affected, and if you need to turn off your camera, please send me a chat in the chat box, and I will make note of that. Also, just a reminder to remain on mute unless you are engaging with the trainer. So without further ado, I'm going to turn it over to Dr. Jakubczak, and we'll go from there. Thank you so much.
All right. Thanks, Tom. Thanks, Ann. Thanks, folks, for having me. As Ann mentioned, a lot of the slides that you're going to see are going to be specific to veterans and military populations. Partly that's because I've done other trainings for VTSC, and this was one that I thought would be relevant given the request. I do want to make a point now and throughout the presentation to just let people know that these patterns, the relationships that we're going to see between PTSD and anger and aggression are true for all populations. There's nothing really specifically unique about the veteran or military populations. And I think that's important to note, especially given some of the stereotypes that exist out there. However, you'll find that a lot of the research on this topic does draw upon studies that have been conducted with veterans and military personnel. And in part, that's because of the just public awareness of this issue, but also because, frankly, a lot of the research is funded by the VA and the Department of Defense. And so there's a skew in the focus of the populations, but you'll find that the findings are going to be relevant. I'll stop throughout, and if people have questions about their particular experiences or populations or setting, please fire away. I also, because time zone differences and some confusion, thought we were starting a couple hours earlier. So I will speed through some of the things that I think are less relevant and prioritize opportunities for us to talk and dialogue, if that's okay. If anyone wants me to slow down to a particular slide, just shout at me. All right. So in the time that we have, I'm going to review some of the research that we know related to post-traumatic stress disorder and how it impacts some of the aggressive and violent patterns that we've seen. I'll talk about some common tools used to assess for violence risk assessment, and then talk specifically about the impact of emotional dysregulation, so people's difficulty kind of modulating, adjusting their emotional experiences and aggression and violence, as well as the impact on social networks. And then finally, I'll review some of the research to date on anger management and other interventions used to try to mitigate anger and aggression. So first, just quickly to get on the same page, there's different terminology that you're going to hear throughout the presentation. And I just want to be specific that when I'm using the term anger, I'm talking about an emotional state. So it may or may not be detectable to the outside world, but someone's subjective experience is anger. As opposed to aggression, which can be both nonverbal and verbal or physical actions, often experienced as intimidating or threatening by others. That can include destroying property, yelling, verbal threats, etc. And then finally, I really want to carefully demarcate the use of the term violence. So acts of aggression that cause significant harm, physical or emotional harm to the target. So under the current definition of PTSD, there are a number of different aspects or features to the disorder that are relevant to understanding anger and aggression. First of all, there's a physiological reactivity. When someone is triggered either by an internal reminder or an external reminder, their heart rate, their body gets amped up, and that kind of primes the pumps in a lot of ways for anger and aggression. You'll also see that there are just kind of permanent changes in people's emotions and their views of the world, including tendencies to blame themselves or others, sometimes resulting in shame or a kind of hostile view of other people. Persistent feelings of not only anger, but also internally experienced guilt and shame. Importantly, and relevant to later discussions, interpersonal detachment and what's sometimes referred to as emotional numbing, kind of a checking out of emotion states. And then more obviously, feelings of irritability, aggression, reckless self-destructive behaviors, and hypervigilance. I also always like to point out that PTSD is not really a categorical disorder. It's something that fluctuates, and it's hard to always keep this in mind because the way we use diagnostic tools, if someone doesn't meet full criteria for PTSD, the other diagnoses, historically, it's been anxiety disorder. Now there's an other trauma-related disorder diagnosis, but it's not always well captured when someone dips below the line of threshold PTSD. However, what we know from looking at research is that PTSD waxes and wanes, that sometimes people meet full criteria and then some of their symptoms remit and they fall into this kind of subthreshold category, only later to have the symptoms reemerge at a more severe level later in life. What we do know is that subthreshold PTSD is associated with significant impairment, including suicidality, anger, aggression, and unfortunately, folks with subthreshold PTSD or subsyndromal PTSD are less likely to seek treatment, either because they don't recognize the import of their symptoms, or because providers don't. So going all the way back, this issue of PTSD in relationship to anger, aggression, and violence really emerged in the scientific literature following Vietnam. And if you look at some of these statistics, again, I'm not going to go over them in detail, but what you see is that there are high rates of anger and aggression perpetrated in Vietnam veterans. Now, if you notice the dates of some of these studies, you'll recognize that that's how those patterns looked 15 years after many veterans were coming back from Vietnam. So these are persistent patterns that don't just disappear over time. Myself and others conducted some research early in the Iraq and Afghanistan era cohorts coming into the VA, and ours was one of the first studies to see whether or not the relationship between PTSD and anger and aggression persisted in the younger population. There was a lot of, at the time, there was a lot of societal, cultural conflict during Vietnam, and so it was unclear, did that shape the anger, aggression, or was it more PTSD? And also, would a younger, kind of purely voluntary cohort, demonstrate the same patterns? And what we found are high rates of anger, aggression, and violence, with almost a quarter of them reporting destroying property, 25 to 40% of them threatening people. And what was really interesting is we found that 10 to almost 20% of people had reported a physical fight in the 4 months prior to seeking care. That may have informed why they came in to the VA finally. Other people have found similar rates, high rates of violence. So Elbogin and his colleagues found almost 10% had reported severe violence. 25% had reported kind of moderate levels of aggression and violence. And I don't mean to minimize, hitting, slapping, kicking, but relative to threatening someone with a weapon or causing someone, severe physical injury, the more moderate level is very persistent. And what you'll see, and what we'll talk about here, as we get going, is that once you add alcohol into the picture, things really do change significantly. So Elgin did another study using that same population and was looking at kind of the predictors of different levels of violence. He found that severe violence was more likely among younger veterans with more combat exposure, and as I mentioned, alcohol misuse. Being older or feeling as though you had some control over your life was protective. That moderate level of aggression and violence was predicted by prior history of arrest, combat exposure, again, alcohol misuse and PTSD. Having good social support was protective, and also a sense of resiliency, and having your basic needs met. All of that kind of makes sense. We also looked at PTSD in relationship to different levels of aggression and violence. What we found is that if veterans had kind of low levels of PTSD, but had alcohol misuse present, they were more likely to report non-physical aggression, so some destroying of property, threatening people. But at higher levels of PTSD, we didn't see any difference between those misusing alcohol and those without. So PTSD was really kind of driving that relationship. And those with higher levels of PTSD were also more likely to report physical violence. Again, at those higher levels of PTSD, we didn't see a difference in alcohol misuse, but we did find similar findings as to Elbergens. Younger veterans, those with greater combat exposure, were more likely to report aggression and violence. Interestingly, there hasn't been a lot of research on gender differences in aggression and violence. In general, if you look at the general population, what you find are comparable levels of interpersonal violence and aggression in men and women, though it's frequently argued that some of the aggression and violence perpetrated by, for example, females in a heterosexual relationship, which a lot of this research is based on that, and it's dated. A lot of that aggression or violence may be in a kind of a self-protective or, kind of response level context rather than initiating aggression and violence in relationships. If you look at some of the studies of Vietnam era veterans, what you can see is that 32% of female Vietnam veterans reported aggression and violence compared to 41% of male veterans. That's statistically different, and 10% is not to be ignored, but still the rates, almost a third, are significant. And as you see in some of these other studies, sometimes women are found to perpetrate or report aggression and violence at similar rates compared to their male counterparts. So I mentioned earlier the context of this being military veteran populations, but you'll see these same patterns if you look at the smaller body of literature of research in civilian folks. And so let me take a pause here and see if people have any questions or comments about anything that we've covered so far.
I have one question. Is there any research about opiate use among veterans and PTSD and anger?
Yeah, thanks, Jamie. There is considerable evidence that suggests that PTSD in general increases the likelihood of substance misuse, abuse, and addiction. And there's this kind of a pervasive theory that it's self-medication. And I think that's probably true. And especially in the civilian literature, but also in the military veteran population, what you find is that a prior history of substance abuse also increases the likelihood of trauma exposure. So it kind of goes both ways. And some of you may have found this in your population, that if they are dealing with drug or alcohol abuse or dependence, they are often in riskier situations. And so they may be more likely to be exposed to trauma and develop PTSD, even if that wasn't present beforehand. There's not, to my knowledge, there's not a huge body of literature specific to opiate and aggression and violence. It's most often alcohol because that's what's most prevalent. But in general, if I had to hazard a guess, I think anything that disinhibits emotional control, that kind of puts someone in a more impulsive state, is probably going to increase the likelihood that they act out aggressively or violently. So I don't know if that's been your experience, Jamie, or others, but I would assume that probably goes hand in hand with opiate.
I have a question. I was wondering, I don't know if I misread this because there were quite a few research points, obviously, but did I read correctly that veterans of Iraq and Afghanistan are far more likely to engage in domestic violence relative to veterans of the Vietnam War? And if so, is there any kind of perhaps more sociological speculation as to why that is?
Yeah, at least some studies have found that to be true. And, you know, I don't say this with 100% certainty, but I think probably many people would agree with the idea that, well, one, research wasn't really active immediately following Vietnam. It really took several years for folks to think, oh, we should ask these people what their experience was. So by the time a lot of these research studies were conducted, it was 10 or 15 years later, which means if those things had occurred, they may not be as imminent in someone's memory, or they may not feel as relevant, or even some of the assessment tools might not have captured that time frame. It is also the case, though, that in general, not specific to PTSD, but in general, aggression and violence tends to decrease over the lifespan. Younger people are more impulsive. They're also more likely to act out in impulsive and sometimes angry and aggressive ways. So I think probably the combination of when we ask the questions and also the age cohort would suggest that there is probably higher risk. Now, here we are almost 10 or 15 years after some of the first waves, you know, folks have come back from Iraq and Afghanistan. So we may also be seeing some of this trailing off pattern. But I'll speak from my clinical experience. I've seen people carry problems with anger, aggression, and violence throughout their lifetime, even into, you know, I've worked with some 75-year-old veterans who are getting out of their car on the side of the road, ready to go at it. Not always quite sure, you know, I'm like, do you realize you are also a chronic pain patient? Do you realize you've got cardiovascular risk? Like, but nonetheless, that's still part of the clinical presentation.
Matthew, I have a question.
Yes.
This is Paul Stibba, King County Veterans. With the research, was there any correlation shown or whatnot comparing number of combat tours with the current population of veterans versus Vietnam era veterans? I mean, I know there were multiple combat tours by individuals in Vietnam, but I don't think it's as prevalent as the current batch. So was that, do you know if that was examined or, you know, what the results of that were? Well,
thanks, Paul, across cohorts, whether we're talking about World War II or Vietnam or Iraq and Afghanistan, higher combat exposure tend to increase the severity and the chronicity of PTSD, which tends to then increase aggression and violence risk. So yeah, I think that's true. I mean, when I first came to the VA, I was primarily working with Vietnam veterans, and those that had served 3 tours, you know, 2 or 3 tours were really kind of standouts. By the time I was working with OEF veterans, which is that acronym for those conflicts given by the DoD, I was seeing people that had 5, 6, even 7 tours underneath their belt. And so, you know, it becomes a little mind-boggling to think about, to try to quantify how much trauma exposure they might have had. But, you know, I think the rule holds true. The more you see, the more you experience, the greater the PTSD, including some of the numbing and anger and moral injury that you can see. And I think all of those things then predispose someone for aggression and violence. These are great questions, folks. Please do stop me as they come up. I'm going to hit a couple more slides, but then pause again for us to see where we're at.
Hi, I have a, this is Tita with the Khmer community of Seattle, King County. I have questions about, I mean, you're talking about the Vietnam veterans and of course, you know, Cambodia during the genocide right after the Vietnam War. Our community, you know, experienced a lot of the PTSD that's went undiagnosed, and so you have a lot of problems in the communities. And so just curious about the secondary, trauma that, continue to the next generation, right? So that still carry on. So is there any research done in that area and the impact? Because I see to this day that we still, see a lot of these issues in our community. Thank you.
Again, I've worked with trauma and PTSD all my life and all my professional life. And one of the things that's most heartbreaking, and I'll talk to this point a little later, is the impact on families. And that can be the immediate family, but also intergenerationally. And what you find is that if you are a child of a veteran or even a person with PTSD, you're at greater likelihood of having depression, anxiety, substance abuse, probably because of living with those symptoms every day. It's not just the person who experiences the symptoms, but also all the people around him or her that also experience the symptoms. And so there is this intergenerational transmission of trauma, and that it comes with anger and aggression. Interestingly, there have been some studies that have demonstrated a strong genetic kind of biological marker for PTSD. So a lot of these things are, we think of PTSD as informed by your experiences, and that's certainly true, but there may be some genetic vulnerabilities that also run in families. And so, maybe that you have a genetic loading for depression and anxiety, and then if you experience trauma, you're more likely to develop PTSD, and then, your offspring are also similarly more vulnerable depending on what you experience. So sadly, that is the case. Trauma begets trauma. I'm going to keep going through some of this. I just want to, again, highlight the idea that I think there's a stereotype of, angry and violent men, male combat veterans, or I also work a lot with first responders, so police, firefighters, EMTs. And I think there's a stereotype of the male client, the male patient having anger and aggression. There is some evidence to suggest that the severe forms of anger and violence and aggression are less prominent in women, but they may not be less prevalent, if that makes sense. So there may be some gender socialization that really kind of informs the expression of those internal states, and or people aren't asking. I updated these slides in anticipation of this, and I expected, since the last time I gave this presentation almost 5-6 years ago, oh, I bet you there's been more. No, there hasn't been any more research on women and aggression and violence. And also I have a last 3-4 years an interest in transgender, treating trauma within the transgender population. And there's not a lot of research. There's a lot of research on being the recipient of violence, interpersonal violence. I haven't seen any research studies yet on anger and aggression perpetration among transgendered persons with trauma, but clinically, I've seen those issues. So one of the things to keep in mind is, if you're working, and I would say this is probably, to be mindful of this, regardless of your setting or even your role. It may be very relevant to know whether or not someone is struggling with aggression and violence, but you won't know if you don't ask. And, we'll talk here in just a minute about some ways, because it can be a subject matter that's, can create some anxiety. If I ask this, am I going to upset them? Are they going to become angry with me? And yet, if we were a medical doctor and someone had, a risk factor for any number of different negative outcomes, not asking, clearly wouldn't be in the patient's best interest. So I would encourage you to consider asking. This was a study out of the Tacoma division of VA Puget Sound, and just shows the rates of interpersonal aggression and violence, 61% among veterans with PTSD. Okay. So I'm curious, maybe that's a good segue. how do you guys experience this in your setting? Do you see evidence of anger and aggression linked to trauma? Do you ask about it? How does that go? I will just share it. This morning I had a conversation with a veteran who, combat veteran across eras, Vietnam, Iraq, and he was in Vietnam, Iraq, and Afghanistan, plus some other missions. And he disclosed that he had PTSD to his dentist, and was fielding all these questions about, are you prone to anger and aggression and violence? And it pissed him off, excuse my language, but it made him angry to have that. And yet it's really relevant. It's something that we talked about. Well, here's probably why they're asking. They may not have asked in the best way, but here's why they're asking, is they want to be mindful of what happens if you're in pain and they're looming over you, and they want to make sure that you're comfortable. Even in that setting, it's probably relevant to clinical care.
One thing I could say is I'm the volunteer coordinator for the 24-hour crisis line in King County. And we sort of take it as a principle in the way that we train our volunteers that though it may be uncomfortable to ask about certain emotions or actions, that verbalizing them and specifically isolating them is an important way to demonstrate one's willingness to meet somebody where they're at, and to show a willingness to discuss what are usually very difficult topics for people to address in the real world.
That's such an excellent point. I think, a lot of the folks that I worked with over the years worry, like, you're asking these questions, but can you handle the answers, right? And that both means sometimes it's fear that what they're going to tell me is going to damage me. But also I think it's a soft probe for, will you be respectful? Will you treat me well when I answer this question? And I think a lot of times, especially when people are experiencing guilt or shame, or I used the term moral injury before, around perpetration of aggression and violence, it's a very sensitive subject for them. And so to disclose it, is important. And you asking about it, as you said, it kind of signifies, I'm ready to hear this. I'm asking because I want to know.
Matthew, Paul Stabick again.
Yes.
Anecdotally though, how often are we asking somebody who may have PTSD from a sexual assault or a hurricane or anything else if they are violent or have violent tendencies? But I'm willing to bet that, a lot of us vets are, just because of the source of it. But, if, again, I don't see us asking a rape victim if they are violent or lash out. And I think it's could be perceived oftentimes by the veteran as a bias. And potentially if we're not asking other people with that diagnosis if they are violent.
Sure, and I would agree. There's a stereotype out there, and if we ask this clumsily of veterans or of men, or of other populations that are just kind of presumed to be at higher risk, there's all sorts of stereotypes that exist in the world. And unfortunately, sometimes, i.e. often, that informs who we ask what, right? And so that's a good check on ourselves. Like, am I asking this question of, a particular kind of client, a particular, background? And if so, why am I not asking this other person? And the research would suggest, that if you've been the victim of sexual assault, you may have violent fantasies. And in fact, your fear of your anger and violence, acting out, can have huge implications for your response to treatment. So I would argue, and as you'll see in future slides here, it's something that we should do every time with every patient, and we should still pay attention to who it is that we're setting across, in a culturally competent kind of way. But excellent point, Paul. Yeah. So
there's, excuse me, there's also a comment in the chat that you probably can't see. Zach is saying, I work with folks with intellectual or developmental disabilities, and most of those folks have some form of PTSD. It's hard to know where the disability ends and the PTSD begins.
Yeah. Zach, thank you for that comment and observation. I've seen in my clinical practice that sometimes when people have cognitive or intellectual disabilities, they are at greater risk of victimization. And it is hard to sort out which symptom belongs where. This is a whole soapbox, but I think sometimes we can get lost in parsing out diagnoses and lose sight of the forest for the trees. If we're seeing anger and aggression problems, we can and should pay attention to that regardless of where it fits diagnostically. But it is sometimes hard to sort out. And there are some occasions where the way you would address anger or aggression in a client would differ depending on what its origins are, what the etiology is. But excellent point. So, apropos our conversation, common mistakes when assessing for violence, especially in veterans, but maybe other populations, false assumptions based on a person's individual characteristics or influence of their own clinical reactions. So if someone is coming in, highly distressed and cursing and loud, that may change our appraisal of their likelihood, their tendency towards aggression and violence. Sometimes that's accurate information to weave in, and sometimes we have to check our own bias about that. In general, it's really helpful to get, when you're trying to get a sense of someone's risk for perpetrating aggression and violence, one of the best predictors is their history of aggression and violence. So looking at what their history with violence has been, and looking at dispositional factors like age. I do a lot of research on masculinity. I grew up in Montana. It's the water to the fish out here. And there are attitudes often about what it is to be a man that greatly inform, risks of aggression or violence. Historical factors, features of the trauma exposure, in this case, combat exposure, but if you're working with police officers, it's very helpful to get a sense of what their trauma history looks like. If you're working with refugee populations, really important to get a sense of what their trauma history looks like. And obvious clinical factors like PTSD and alcohol problems, self-esteem, shame, but also contextual factors. What do their relationship status look like? Are they employed? Do they have children? What other factors might be informing their presentation right now? I'm going to synthesize this a little bit, but just to point out that whatever your initial assessment might be for their likelihood of aggression and violence, that's not static. It's something that likely will fluctuate over time. So this really should be an ongoing assessment process. In the same way that you would assess for changes in suicidality, you should assess for changes in aggression and violence. And this is a nice little visual that Albajan created, which is helpful. I think Tom can or will provide these slides, so people should certainly be able to take these home with them as a reference point. There are some tools that exist for assessing aggression and violence in kind of paper and pencil form. And depending on the context that you work, these may be preferable just in a pragmatic way. For many years, I worked in a primary care setting where you had 30-minute slots with people. And so you had to gather a lot of information really quickly. And having someone fill out a self-report measure may not be ideal, but it's efficient. And you'd be surprised at how often sometimes people might report something on a paper and pencil measure, more likely to report it in that form than they would be when asked interpersonally. But you certainly shouldn't rely.
Off-site. See you tomorrow.
You certainly shouldn't rely on self-report measures. You should also kind of follow up any sort of positive responses with queries, and also ask, you know, I see that you didn't indicate any problems with aggression or violence. You know, has that ever been a concern? Might just do one more sweep if the measures look negative. Just some general things to think about. These are general characteristics that are associated with greater tendencies towards aggression and violence. Obviously, explosive anger, but also more subtly, people's tendency to externalize blame. It's never my fault. It was this other person. If only they hadn't done this, I wouldn't have had to do that. Also, minimizing the consequences of aggression and violence. Keep in mind that in relationships, you'll often see cycles of violence. And this isn't just true in intimate relationships, but more broadly, that someone may kind of explode and perpetrate aggression and violence, and that action is followed by a period of regret, remorse. I'll never do that again. I promise. Courting, kind of reestablishing, only then to have perpetration reoccur. And we'll talk a little bit more about that when we get to emotional dysregulation. But interestingly, people's fear of anger and other emotions can sometimes prime the pump. When you're sitting on top of your anger and you're worried about it getting out, it tends to build and can actually potentiate future aggression and violence. And obviously, there's shame and guilt. Now, in my almost 20 years of doing this work, I've come across some folks that would fit into the kind of the sociopathic, you know, true antisocial presentation. It's probably been 5, you know, maybe 7 folks in almost 20 years. More often what I see are people that would meet criteria for an antisocial personality disorder diagnosis, but also have attachment injuries, have sincere regret and shame. They are out of control, and wouldn't kind of be best thought of as sociopathic. I'm going to pause for a second. Any thoughts or comments about any of the last couple slides? I will say that the 5 to 7 times that I've sat across from someone that really I think was sociopathic stand out. I remember those cases very well. It was very unnerving. So I want to talk a little bit about what is sometimes termed functional analysis. And I really like using this lens to understand aggression and violence, and it goes back to Zach's comment of, you know, well, what does it belong to diagnostically? That can be relevant, but what's more of interest to me is why is it happening in that context? What's happening when someone explodes? And in a kind of a basic way, if you can assess, well, what was going on in the moments or even days before the aggression and violence occurred, what was happening while it occurred, and what were the consequences afterwards, you can start to see that there's often a function to people's anger and aggression. A lot of the male veterans that I've worked with have found that, I don't think they did this consciously, but they found that if a partner or a family member starts, in their words, poking, pushing my buttons, but what they really are describing is someone reaching out and saying, how are you doing? Is everything okay? They're probing for emotions, and that can feel very vulnerable. And often the folks that I worked with have found that if they bark or even bite and explode, those queries disappear. The people learn to just walk on eggshells and give them space. And so the person may not be thinking, oh, you know, one of the ways I regulate my emotions is to send off, you know, get away signals when I'm feeling vulnerable, but that's exactly what they're doing. And if they can understand that that's the function of their anger, they don't like the outcome of the anger aggression, but they are trying to modulate that interpersonal experience of, you know, vulnerability. And so if that can be made explicit, then you can come up with alternative strategies on how someone might do that. Hey, I'm really upset right now. I'm so afraid that if I start talking about it right now that I'm going to lose it. But maybe let's step back a little bit, think about what's going on, and maybe we can talk about it later. That's a little bit of a utopian example of what might happen, but it's something to strive for. I'll always make a point of when I'm working with my clients, even if PTSD is driving a lot of your anger and aggression, it doesn't mean that PTSD gets to be the kind of the scapegoat explanation for it. It's not like, well, sorry, I've got PTSD. That's why I did that thing. That's really just a jumping off place. Well, let's understand how and why your PTSD is bringing you to that point. Not that you escape responsibility for the outcome of that. What I have found is that when people go through this functional analysis and they start to kind of understand better themselves what happens that puts them close to aggression and anger, they feel a huge sense of relief. It gives them more control. They're better able to predict their own anger, which is, you know, a huge factor in helping them manage it. So I'm going to jump into this term, kind of emotional dysregulation. But let me just pause for a second. Any comments or questions before I move on to this next topic?
You talked about when people claim, you know, poking and prodding as kind of setting them off, and the resulting outburst is, you know, the anger stops people from asking, which is the goal. But how do you account for the more, what I said, what I'll call passive triggers, such as smells, sights, sounds, that really trigger a physical outburst or a manifestation of what's going on? How do you account for that?
Yeah, the metaphor I use with a lot of the folks that I worked with is that PTSD is like being handed a sports car with a V8 engine, fuel injection, but really thin brake pads. And so it's really easy to accelerate your physiology. So sights, sounds, smells, even things that aren't direct triggers for trauma, but that are just irritating. You guys won't hear it because he's over at his grandparents' house, but I've got a 4-year-old. Love that kid. And at a certain pitch, you know, it's like things get activated. So anything that increases our physiological arousal is going to prime the pump for that fight or flight response. So sometimes anger aggression is used instrumentally. It's used to kind of terminate feelings or change people's posture towards us. And sometimes it truly is just a reflection of too much arousal without enough containment, you know, kind of the glass is overflowing. And so another thing that I often help people track is their level of arousal throughout the day. Like you get up, can't find the car keys. Okay, I just went from 0 to 5 miles an hour. Car won't start. Now I'm at 15 miles an hour. You know, I'm on my way to the VA for my appointment. I start thinking about the last time I was there and I had this bad interaction with the pharmacy. Okay, and now I'm at 55 miles an hour. I get in there, my doc is running late. Okay, I'm already at 85 miles an hour. I'm over the speed limit. And when they sit down and they say, you know, let's talk about anger and aggression, bam, it explodes. If you're monitoring your arousal throughout the day, you're better able to modulate it. And again, you get that sense of perceived control. But I think all of those triggers that you're talking about, Paul, you know, just kind of prime the pump. They add fuel to the line. Yeah. So I want to talk about this idea of emotion dysregulation. And you know, sometimes when I've given this presentation, people are like, well, isn't emotion dysregulation the same thing as anger and aggression? And I would say yes and no. But what I mean by emotion dysregulation is that people are able to identify what they're feeling, put words to it, communicate it. If they're regulated, they can do all of these things. If they're dysregulated, they can't. I don't know what I'm feeling. I can't put words to it. I can't control the behaviors associated with this mood state. I feel out of control. I'm trying to suppress it, but that often doesn't work. You know, it's for me, it's like, you know, the image of having a Great Dane, a 2-year-old Great Dane on the leash. It's like you're just being dragged by this. You're not really in control of the situation. And we know that PTSD impacts emotion dysregulation, both in kind of interpersonal contextual factors. Combat or a violent home confuses someone's ability to manage their emotions. The things that happen during trauma exposure are often hugely intense fear, horror, anger, rage. And then afterwards, there's this kind of cascade of guilt and shame and resentment, sometimes emotional numbing, depression, and then a fear of emotions. I don't want to be activated at all because I'm afraid that I'll lose control. And sometimes people can't even tell the difference between what is a physical reaction and what is an emotional reaction. So, not surprisingly, the research tying PTSD and emotion dysregulation is pretty consistent. The more trauma exposure, the greater the PTSD symptoms, the greater the emotional dysregulation. Going back to this idea of anger or aggression or violence having a certain function, it's hard to feel grief when you are enraged. It's hard to feel, you can even change your subjective experience of fear to anger or rage by rearranging your perceptions of the situation. And although fear and rage are physiologically identical in our bodies, anger, violence tends to be experienced as gaining control over. And so if you have a choice between helplessness and control, often people will choose control. As we've talked about, it can terminate difficult discussions with other people. It can create distance. It's also intoxicating. A number of the folks that I've worked with over the years have told me that they really miss combat. And when I query and ask, well, what does that mean? They miss that adrenaline high, right? And that makes sense to me because that intense rage comes with the body's own version of opiates flowing through your system. You can't feel pain very well. It does terminate these other emotions. It creates tunnel vision, so you decrease the amount of stimulation that's going on. A lot of people really enjoy being angry. Not the consequences of it, but the state of it, if that makes sense. Any comments about any of that?
That I was just going to ask, how in the research is it usually, how is emotional dysregulation isolated? So how does one ask whether or not they're healthily regulating their emotions?
There's a great self-report tool called the DERS. Dysregulated emotion, I'm too old to remember, but DERS. The author is Kim Gratz. I actually went to school with Kim, and she created this instrument, which is, I think, probably the most widely used instrument. If you read the instrument, you'll get a sense of things to ask. But in general, what it means to me is, are you aware of your physiological arousal? Do you ever find that you're more amped up than you realized? You're kind of surprised by where your body's at? Do you find that it's hard to identify what you're feeling in certain moments? Is it hard to put words to it? Are you confused? Does it ever feel like there's kind of a blurry line between where your body's at and where your head's at? And do you find that when you are kind of activated with emotion, you end up doing things that later you regret or that you wouldn't have done otherwise? Do you ever find that you are trying to sit on or suppress different emotion states only to find that later they kind of bounce back? You get that Jack in the Box, kind of experience where all of a sudden it springs out at you. Those are kind of questions or threads of a conversation that I usually use to get at that idea. One of the things that we know is emotional suppression, which is a huge part of emotional dysregulation, really does lead to a spring back kind of phenomenon. And you can see it. If you ask people to withhold their emotions, what actually happens is their heart rate goes up. The amount of sweat on their body goes up. A million years ago, when I was in grad school, we did a research study where we had people watch, I'm dating myself and many of you may not get the reference, but there's a horrible sexual violence scene. Oh, now I am old. It's a Deliverance. I think it's the movie Deliverance with Burt Reynolds. And it's a male on male sexual assault scene. And we had some people watch the show and said, feel whatever you're going to feel. And we had other people watch the show and we said, whatever you do, try to control, suppress your emotions. Don't let anything show on your face. What we found is that people that were allowed to process their emotions while they were watching the film went up and went down. What we found is that people in the suppression condition went up and stayed up. They were just kind of stuck at this higher level of arousal, which then increased the likelihood of them acting out in the study verbally in a later scenario. So suppression carries over. I'll talk about it sometimes with patients as like a credit card bill. It's like if you don't process your emotions while they're happening, they gather interest, you know, they balloon, the payments balloon. Okay. Any comments and questions about that? Is this pace okay? I am trying to clip along, but if people have comments or questions, please jump in there. Do people use any sort of assessment tool, like an intake packet, where they assess for anger issues, concerns about aggression or violence? Okay. I brought up the impact, and we've already put words to the ways in which PTSD and specifically aggression and violence can impact relationships around the person with PTSD. This is incredibly relevant because the number one factor that predicts resiliency and recovery from trauma and PTSD is social support. When you have positive social support, you tend to recover quicker from trauma exposure. That's the good news. The bad news is that PTSD and anger and aggression quickly erode social support. It doesn't take many times of someone yelling or throwing, breaking something, or being violent or aggressive towards someone before those relationships start to be distanced, right? And some of that is naturally, even if they're in the same household, those relationships mean less emotional closeness. But often it just means people won't return your phone calls or your emails after you've blown up at them, right? And so many of the folks that I've worked with over the years, when they come in 10 or 15 or 20 years after their trauma exposure and you ask them about their relationships, they have virtually none. They are multiple times divorced. They are alienated from their family. And what relationships they do have are often kind of surface level. I can't tell you how many times someone, when I asked, like, tell me about your friendships, and they say, I don't have friendships, I have acquaintances, by design, right? So not only does it help with resiliency and recovery just in general, but social support is a huge predictor of people's response to psychotherapy for PTSD. This goes back to the question asked earlier about intergenerational trauma, but the spouses and intimate partners of persons with PTSD report an increased kind of caregiver burden, kind of a burnout from taking care of someone that's chronically distressed. It increases their risk for depression and anxiety, and as we already noted, it negatively impacts parent-child relationships.
Can I quickly just ask for that slide, was that still research on veterans, or is this more?
It was, but this is another one of those things that's universal. PTSD,
Okay.
PTSD it's this huge irony. The best thing for PTSD is social relationships. The worst thing for social relationships is PTSD, right? So it's like, you know, the very symptoms that are present erode and deteriorate one of the best protective resiliency factors around. And perhaps not surprising if you think about it, the features of PTSD that tend to be most responsible for the deterioration in relationships are emotional numbing and detachment. You know, spouses, family members say, like, I don't know if you know, my partner loves me. I don't know, you know, it seems like they're always just kind of checked out or distant They don't talk as much about their internal experiences. They don't talk about their traumas, but they also don't talk about the day they just had, right? It's kind of like this idea of a floodgate. If I open this door, everything's going to come pouring out. There's a lot of negative emotionality, and of course, anger and aggression and violence do huge damage to relationships. I think I probably won't go too much into this case study, but I wonder, just for the sake of time, but I wonder if other people have any examples of folks that they've seen that have PTSD, and you can tell that the PTSD has done damage to their relationships. Or more broadly, just seeing the ways in which people have tried to help someone with PTSD, but the symptoms are interfering with that offer of help.
This is Catherine. I work at the Issaquah. I work at a senior center, and we have veterans, oftentimes homeless, that come in. But it's the explosions of anger, whether it's outside or inside, it gets a reputation, and then other people are avoidant or hesitant.
Yeah.
So it's been, as staff, you know, we try to be, you know, engaging and, you know, accommodating, but it's really hard for others. They don't want to be around them. They don't understand why we don't, you know, ban them.
Yeah. That's such a great point. I mean, obviously it's going to impact the other clients, right? But as Catherine noted, it's also going to impact our relationship with our clients, right? It's really hard to get yelled at or feel threatened and then go back in the same day. I mean, we do it because it's our job, right? And hopefully we muster a little bit of, you know, open-heartedness. But after someone has ripped into us 3 or 4 times, you know, it often feels like you're reaching out to put your hand on the hot stove. It's like, okay, I'll do this, but are you just going to bite me again? And the clients that you're talking about, Catherine, you know, older veterans with PTSD that are homeless have probably burned through, I don't know how many different relationships over the years, which kind of informs how they're presenting to your facility, right? Yeah. All right. So let's talk a little bit about, I think we're on a good mark for time. I would like to ask people to start banking away questions or observations so that we can have some open discussion here at the end. But let me talk a little bit about some of the treatment strategies for engaging persons with PTSD and anger and aggression. And this is another one of my soapboxes, but you know, there are all these well-established therapies for PTSD, and they're often 12 different session therapies. And what you find, and they've been widely disseminated in the VA and out in the community. I mean, the number of, you know, in the last 30 years, the number of people that have been trained to deliver things like prolonged exposure, cognitive processing therapy, you know, CBT techniques for PTSD has just skyrocketed. But if you look at the utilization of services among persons with PTSD, what you usually see is this pattern of them coming in, dipping their toe in, leaving, coming in, leaving, coming in, and usually kind of at some critical point, it's usually about 8 to 12 years after their initial diagnosis of PTSD that they come in for a minimally adequate dose of treatment. And when I say minimally adequate dose of treatment, that's like 8 therapy sessions in a year, or 3 or 4 visits with a med prescriber. It takes people almost a decade to come into care, right? So when you are seeing someone newer to a diagnosis, or this is kind of a newer step into seeking treatment, I really like to emphasize that we need to anticipate that many of those folks won't come back. So how do we hook them, right? How do we engage them? And I think one of the best strategies that I've seen is called motivational interviewing. And it's really an empathy-based, reflective listening kind of strategy where you note that people are coming in with ambivalence. It's probably really scary for you to be in here today. And I'm guessing that you don't want to talk to me about these things. You haven't wanted to talk to almost anyone about these things. And so, you know, you're probably not super thrilled to be here. And there must be enough going on in your life that has brought you here that says maybe something needs to change, right? That kind of open-palmed offer of help is very different than, you know, you have PTSD and we really need to get you into care. Let me schedule you for some sessions, right? And taking that extra time in the beginning to weigh out their indecision, their ambivalence, is shown to have huge impact on their engagement when they do come into care. Interestingly, or not surprisingly, both, problems with anger is often what brings people into care for PTSD. They're not coming in to talk about the thing that happened to them in Fallujah. They're coming in because they've been given an ultimatum by their partner, by their spouse, or they're tangled up in the legal system, right? Or their kids won't talk to them. And so, you know, it's usually anger that drives people to seek care. Many people have learned over the years to be afraid of their anger because of its impact on other people or because of its ramifications for the legal system. Or in the case of combat veterans or other people that have perpetrated aggression and violence, there's huge shame and guilt. So they don't want to even get close to their anger. But unfortunately, when people are afraid of their anger, they tend to lean back from all of their other emotions. And most treatments for PTSD involve the processing of emotions. It's like going back to that emotional dysregulation. And so if people are leaning away, saying, yes, I want treatment, but I don't want to feel anything, it makes it really hard to engage them in care. And in fact, fear of anger does tend to predict people dropping out of care and not responding as fully to PTSD therapy. So there's often this debate. Do you start by treating the PTSD and assume that once you do, the anger and aggression will get better? Or do you start by targeting the anger and aggression, often what brings them into care, and hope that they'll stick around long enough to get the PTSD symptoms also looked at? There are often some imminent considerations, you know, safety considerations, legal consequences, or the deterioration of social support that may may inform the sequencing of care so that you address the anger kind of first thing. So cognitive behavioral therapy for aggression, often, as I talked about, you know, what are the antecedents? What happens in that moment when anger and aggression shows up? Are there other ways that you could have coped with those feelings? There are interventions like dialectical behavior therapy, which is also effective for suicidality, which have been shown to help reduce not only suicidal thoughts, but also violent behaviors. There are mindfulness-based interventions like acceptance and commitment therapy for anger. And there's even some evidence to suggest that doing couples or family therapy with a specific target on PTSD can be effective. The qualification there is, you know, usually moderate or severe violence patterns, recent violence patterns are rule out for a lot of family or couples therapy approaches. Among the cognitive behavioral therapies or evidence-based therapies, I mentioned prolonged exposure. That's a treatment where you get people to kind of go back to the memories and go back to the triggers and learn to process them and habituate to them is effective. Cognitive processing therapy, where you really kind of probe what are the attributions that the person has made about their trauma and how do they see themselves and how do they see the world, and can they re-examine those, kind of readjust those views. EMDR has been shown to be effective. It's kind of another emotional processing intervention. Teaching skills like how to manage stress, how to problem solve, how to activate, increase your activation towards meaningful, pleasurable activities. Those are showing benefits for treating PTSD. And then other approaches include interpersonal and brief psychodynamic, mindfulness, and even mantra repetition interventions all show promise for PTSD. That's targeting the PTSD first. When you look at interventions specific to anger and aggression, again, I'm hard pressed to say that there's a huge success story here. I just re-reviewed the literature. And generally what you find is that there are small to medium effects at reducing anger and aggression in small trials. You can use anger management skills over video teleconferencing, and they have been found to be just as effective as in person. But again, small to medium effects in reducing anger and aggression. There's at least one study that found that if you target anger and aggression, you'll also see a reduction in PTSD symptoms, which is encouraging if you decide to prioritize anger and aggression. This gentleman, Miles, looks like he has followed the thread of emotion dysregulation and created a target that's specific, an intervention that specifically targets emotional dysregulation. In a small trial, he's found medium effect sizes for reducing anger and aggression, which is encouraging. People have said that that should be part of couples therapy. And I also found a study that demonstrates that there are mobile apps. There's an app for everything these days, including anger management, and that can be effective. So some of this is kind of thoughts by Jakubczak, but I think they're generally consistent with the literature, which is, I really advocate for people to adopt a flexible, non-linear approach so that there's always a level of monitoring and engagement. How likely is this person to come back into therapy? And if this might be the last time I see them, what might I say to them? If there are things that are getting in the way of their therapy, problem solving, so that childcare issues or transportation issues, if they can be mitigated, that you can bring them in for care. There should always be a close ongoing monitoring for safety and ongoing risk. Using cognitive behavioral techniques to identify triggers and rehearse what are desirable responses when triggered. Introducing emotion regulation skills and interpersonal skills, how to communicate effectively. And then once all of those things are kind of on board, then moving in perhaps to do trauma processing, whether that's in a structured protocol like prolonged exposure or cognitive processing therapy, or if that's a little bit more organic over time. And really integrating the larger goals of maintaining a positive family, work, community life. And eventually, if people are feeling pretty positive about where they've gotten, helping them think about how not to slip back into old patterns in a relapse prevention type of way. Any questions or comments about any of the treatment considerations or treatment strategies that I've just reviewed?
I wanted to ask a quick clarifying question, and I want to be transparent in saying that my experience in working with veterans is minimal, if non-existent. I'm wondering, and I think you may have sort of touched on this already, but where and when do most veterans' diagnoses of PTSD occur?
It's a great question. And this is true for veterans and civilians. So, well, I'll throw it out. Anyone guess the context in which PTSD is most often first diagnosed?
I would guess police, like some kind of arrest.
I think often it's the legal system.
Or Child Protective Services or some kind of outside organization.
Yep. So when some sort of external kind of consequences come due, I think that's quite commonly the first time it gets diagnosed. In a medical system, the most frequent setting is primary care. People come in for some other reason. Often, I have sleep issues. I can't sleep. Oh yeah? Tell me more about that. Well, it turns out I haven't been able to sleep for years. How many years? 8 years. What happened 8 years ago? I came back from Fallujah. Oh, oh, okay. PTSD has huge negative consequences on all sorts of bodily systems. So everything from GI functioning to musculoskeletal pain to cardiovascular health. And so often people will come in and it's like, wow, I've had hypertension for years. And then the doc is like, and you haven't slept well, and you have issues with anger. Like, but it's worth noting because primary care settings are so commonly the place where PTSD gets diagnosed, but the referral from primary care into specialty mental health care, the success of that is abysmal. It's terrible, right? Sometimes that's on the clinic or the provider, which is like, oh, you should go talk to someone. Here's a list of resources. And the person throws it in the back of their car and never looks at it. But sometimes also it's just an opportunity to skip a beat for the person who doesn't want to address the PTSD. So VA and increasingly civilian sectors are moving mental health resources into primary care and doing an amazing job of capturing that, capturing mental health conditions like depression or PTSD in the same setting. It's thought to be a little less stigmatizing because you're not in a mental health waiting room, you're in a doctor's office. But the trick is then training primary care providers and nurses and other, other staff in a primary care setting how to notice what the signs and symptoms of PTSD are, and then how to have these conversations that we've been talking about today. So excellent, excellent question.
That is fascinating and not reassuring.
Not reassuring in the least, right? I don't know how many of you have had a primary, well, probably this year has been different than most, but in a standard year, most people see their primary care provider once. And my experience, and I've got a great primary care provider, but if I get 20 minutes of her time, like that's huge, right? I usually wait for about 40 minutes for 20 minutes of eye contact. And so in those 20 minutes, especially you think about, I mentioned about cardiovascular disease and PTSD is related to diabetes, and right. So, someone that has been living with PTSD for 20 or 30 years probably has 6 to 8 medical conditions that are going to grab the attention of a primary care provider. And the time and the space required to assess for PTSD is usually, such that it just gets short thrift. Right? Excellent question. Yeah. And going back to Catherine's, I think it was Catherine's point, some good news is that Washington State and other states are starting to develop veterans courts so that when a veteran, and I wish that they were more broad. This is one of those examples where the stereotype gets reified. And what about all the civilians with trauma and PTSD, right? But there are increasingly, I think, in the same way that there are drug and alcohol courts, I think there are PTSD or veteran courts that catch people that have become entangled in the legal system, and then slow down and look to see whether or not they have trauma or PTSD, and if that can be taken into consideration in their sentencing and maybe guide them instead towards treatment. Again, I'm going to skip the case example.
You got some questions in the chat, by the way.
Oh, thank you. Thank you. Yeah. Let's see. How do I get to that?
I can read it for you. There are the recommended strategies when working with vets with PTSD and also self-medicate with drugs and alcohol.
Yeah. I think in general, military and veteran populations are used to straight talk. There's something about military culture. It's like, as I hear my veterans complain about civilian life, it's like, you took 20 minutes to get to the point. Don't worry about my feelings. Just what is it that you want me to say or do? Like, what's the point? And I think there are ways that you can respectfully kind of riff off of that part of the culture, which is, I want to speak plainly with you today. I'm concerned that you're showing a lot of the signs and symptoms of PTSD, and it certainly seems to be relevant not only to your relationships, your anger and your aggression, but also I'm worried about its impact on your health. So can we either schedule another time to talk about that, or can we talk about that today a little bit and maybe move that up the priority of things to address? I think if you speak matter-of-factly, you'll gain more trust than if you kind of are too worried about broaching the subject. And I think as was noted earlier, sometimes just asking in a really straightforward way conveys a confidence that you can handle the answer. So I think one of the recommendations I would put forth is speak plainly. Ask the questions that are most relevant to a person's life and safety, and communicate respect when doing so. And I think that will often be well received. The second part of that around substances, I can't tell you how many times I have helped people understand their use of substances in relationship to their trauma and their PTSD in a way that's, it's kind of a light bulb moment for them. Many people know, like, okay, I started drinking after this. But when you really dial down to, you've been emotionally numb for a decade, and it seems like the closest you can ever come to feeling content, or maybe even almost happy, is when you're drinking. And it probably takes you 6 to 8 drinks to hit that point. Unfortunately, it's a bit of a teeter-totter, because at 9 or 10 drinks, or by the time all those 6 or 8 drinks catch up to your nervous system, then you're in a place where you're feeling out of control about how you act, and out of control with your feelings, and maybe even out of control with some of the PTSD memories. So I can see you trying to dial it in. I can see you trying to kind of hit that perfect spot of being, relaxed, being able to feel positive emotions, but slipping over to a place where you don't want to be. And I think that functional analysis and kind of, empathetically highlighting that they're using substances for a reason. It makes sense that they're self-medicating. It makes sense. It's what's readily available to them, and it works fast. And for many years, it probably works okay until the credit card debt really becomes due. So I think speaking plainly, but with empathy, and helping them understand how their symptoms are related to their substance use goes a long way.
There's a question here from Jess. So many of what you're sharing about the way that PTSD lives in the body and is grounded in arousal, sensation, etc. Yet I don't see many body-based modalities in the treatment strategies. Yoga, meditation, Tai Chi, acupuncture, etc. Can you speak to this?
Yeah. Yes. Hallelujah. Yes, PTSD does live in the body, and some people like Bessel van der Kolk and other people that are doing EMDR, I think often have much more of an appreciation for some of the somatic physiological aspects of PTSD. There's a lot of debate about, if people are familiar with EMDR, you process trauma, and then there's this, it kind of almost looks like hypnosis, but there's this part of the treatment where people revolve their eyes back and forth. And there's a lot of controversy over, is that part necessary? What is that? Is that, is that snake oil? What is that? I don't do EMDR, but when I've heard it described, it makes perfect sense to me that what you're doing is bringing out an emotion, and then you're doing something to kind of regulate the body again. And then you're bringing out emotion, and then you're regulating the body, and bringing people into awareness of their body. And I think that's an important part of EMDR as a psychotherapy. But there is growing evidence that things like acupuncture is effective for PTSD, that yoga has benefit for PTSD, that mindfulness training has benefit for PTSD. And they're sometimes called CAMs, complementary and alternative medicines, medical approaches. Those things are really exploding. And I suspect it's a matter of time and years of research before we find that those modalities are incredibly helpful, either instead of traditional psychotherapy or in conjunction with traditional psychotherapy. Were there other things in the chat box? Let's see.
You all can put your, unmute yourselves if you want to. There's a message in here from Jamie with a link to medication treatment veterans called iRest.
I do want to throw out one more thing, and then we should have plenty of time for open discussion here. But I want to go back to, I think it was Catherine's point, which is the impact of aggression and violence doesn't just interfere with the interpersonal relationships of our clients. They interfere with our therapeutic alliance. I was going to tell a case study. I'll just give you a brief synopsis. I was working with a veteran who, he came into care, heavy combat, 4 or 5 tours, clearly infantry, and in really plain speak, let me know that he was haunted by some of the things that he did during his deployments. And he was there really as an ultimatum. He was there as a result of an ultimatum from his spouse, who said, "You get help or we're done." And I worked so hard to hook him and bring him into care, and we had several visits, and when he didn't show, I tracked him down by phone and got him in there. And one of the things that we decided was that it would be really helpful for his spouse to be involved in our sessions, in our care, because it was such a strong motivator, and if she understood PTSD better, she might help her appreciate some of what he was struggling with, but also I could give information to both of them and not trust that he would just pass it along. They came in for a couple sessions, and I was feeling optimistic. And then I got a call from her after 3 or 4 sessions, and she left a message on my phone. It was difficult to understand because English was not her first language, but in essence, she communicated to me that he had sexually assaulted her in between our last session and when she had called. And it had a huge impact on me. I ran through all the things I try to help my clients with. Could I have seen something? Did I not see that coming? I felt responsible because I had involved her in care. I probably understood that perhaps at least part of what had happened was a result of him feeling dysregulated and wanting to create distance between the two of them. But it made it really hard for me to try and re-engage him in care because, frankly, I was horrified by what had happened. And that's just one example, but I can easily think of 12 more where either anger directed towards me or aggression and violence in general has really, impacted me. Hearing about it has impacted me. And I'd be lying if I said it didn't impact, kind of my eagerness to schedule with someone again. And so I think it's really important that, when we're addressing this topic in our professional lives, that we acknowledge that we seek out consultation, that we document appropriately, and engage in a lot of self-care and decide, when we have, done what we need to do, how do we then also let go of the consequences of the things that we're not in control of? And that's sometimes easier said than done. And I know that also is all relevant for patients that I've had that have committed suicide, but it seems sadly also true of this aggression and violence. So I did want to bring home that point because we are not robots. We are human beings doing this work, and it can leave a mark. I do want to encourage people to unmute themselves and share either in comments. I've now got the comments pulled up, but comments, or I would welcome live questions or discussions, case examples that people might have had that they think would be helpful to share.
I could add that once again, not any specific experience assisting veterans with their PTSD, but that on the crisis line, what we deal with our volunteers a lot is the sort of guilt that inevitably accompanies not knowing what the outcome was or what the consequences of what one said might have been. And of course, because we're talking about a phone line, it could be that somebody just hangs up and that situation is forever unresolved. And I'm seeing a lot of parallels with the sort of inability to perhaps hook a veteran and for them to not show up again and to wonder what those consequences are. And we really do try to actively encourage people to build some community to speak to the people around them about what happened as a means of assisting them generally. But I just saw that parallel and I thought that it was interesting.
Yeah. And it is the case that people that have a history of perpetrating aggression and violence are at increased risk of suicidality. So whether or not it is immediately apparent in the people that you're talking with, and civilian or veteran, regardless, a good portion of them may be sitting on some of these feelings. And it doesn't mean that you necessarily, especially when they're in that kind of fragile state, that may not be the moment to move towards, tell me about some of the bad things you've done, but you might listen for it. And I mentioned earlier this idea of moral injury. If people haven't come across it, it's not a formal diagnosis, but it's this concept that that people have either seen, experienced, or perpetrated behaviors that just kind of go against their point of reference for what is right in the world, right? And combat is one of those situations where people often, it's messy, it's muddy, there's lots of gray. And so people end up seeing or doing things that they wouldn't do in any other setting. And somehow they're trying to reconcile themselves with it. But moral injury shows up in all sorts of different settings. It shows up in the medical field, right? We end up sometimes doing things that we wouldn't necessarily do if we weren't in this professional role. Or we see or hear things like the example that I just gave that truly horrify us, And I bring that up because it's not a formal diagnosis, but I often find that when people are in states of crisis, that kind of moral injury is often related to where they're at. They have been perpetrated against, or they have perpetrated, or they have seen or witnessed something that has just told them that the world is not right, and they're having trouble tolerating that. I also wanted to point out, Catherine, you mentioned where you work. I know from some of my clinical work that issues of dementia end up being highly relevant and also come with features and symptoms of impulse control, loss of impulse control, and anger and aggression. I think Zach had mentioned working with, developmental disabilities or other intellectual impairments. And so not only might trauma impact some of those things, but also changes in cognitive functioning and neurocognitive decline can impact that. And there's a kind of a window, I think, where people have awareness that they are acting differently or doing things differently than how they used to, that brings guilt and shame and moral injury. But there's, truly a loss of ability to control it. I don't know if you found that or if other people have found that.
Yeah, I mean, yeah, we've had older adults who definitely have dementia and have those angry outbursts, and it's really hard to know how best to handle it. And if you usually what we do is we'll say, you know, you're having a hard day, seems like you're having a hard day, maybe you know, you need to leave now, but you can come back tomorrow. I mean, we are a public facility run by the city, so we do have to continue to stay open, you know, to everybody. So,
Yep. Yep.
but it's hard. It scares people, especially
Yeah.
you know, like the homeless. You know, other people are like, well, I don't want to be here because they're here, and it's like, you know, anybody can be here. You know, it's
Yeah.
you don't get to choose. You know.
Yep. Yeah, that's right. Zach, you had asked a question about PTSD with TBI, and that I'm glad you asked that. It's, you know, we think about neurocognitive changes because of the aging process or, you know, dementia processes, but a lot of younger veterans, and I think now the whole country, the whole world is paying more attention to the consequences of repeated but mild traumatic brain injury, not the, you know, I think of severe TBI, you know, people are in comas, they have language impairment when they come out of the comas, you know, and you can see those personality shifts. But what about the repeated kind of more subtle brain injury that can come from football, or that can come from years of physical abuse at the hands of, you know, an abusive partner or an abusive parent, or in the case of veterans, you know, repeated blast exposures. And you know, it's a bit of a lightning rod topic, it turns out, in the research literature, because there are plenty of people who use kind of a civilian point of reference that say mild traumatic brain injury should not be related to this chronic cognitive impairment. And there's some research studies that suggest that really what impacts the cognitive decline over time is the PTSD and depression, more than, you know, organic changes in the brain. And yet, what we don't know, and what the research will probably show later as people, you know, pass away and there are autopsies, there are some signs to suggest that repeated brain injuries do lead to increased risk for dementia. They do result in loss of impulse control over time, and emotional dysregulation, irritability, all of which might impact anger and aggression and violence tendencies. So there's been some famous cases of, you know, I think professional sports athletes who have had this sudden shift in their personality, and suddenly they're acting aggressively and violently. And I think there have been at least a couple of cases where, you know, an autopsy has revealed some structural changes in brain structure, in brain form. So I think we don't know yet, is my opinion. As far as best practices, I think it's very similar to that kind of sequenced, you know, stepped care approach. I was a part of a research study for many years. We were looking at how to best treat post-traumatic stress disorder and TBI. And we combined a present-centered therapy, a behavioral activation, with cognitive skills training. So teaching people memory tricks, you know, like you put your keys in the same place every day. You make lists of things. You use mnemonics to keep track of names and, you know, other things that you need to remember. You use your phone, you know, let's program the things that you're going to do over the week. So all these compensatory kind of steps that you use to help with cognitive issues, and whatever the etiology of the memory impairment and cognitive functioning difficulties, those are useful tips. And so that study's not done, and I've since left it, but if people are paying attention to it. So, you know, I would say if people are having cognitive issues, to address them at the symptom level. You know, how do we help manage memory impairment? How do we help manage anger? How do we help organization and concentration, mindfulness skills to address the deficits that someone is describing? And we can worry later and let the researchers figure out, what's the cause of it. So I don't know if that helps, Zach, but I would suggest that, treating the cognitive symptoms along with the PTSD and depression is probably best practices. Yeah.
What about the idea of, I haven't seen it addressed before, I'm just curious though. I mean, there's a lot of studies, at least on the military side, about, overcoming the natural prohibition against harming or killing another human being. And the military is very good at that from the first day you get there. Everything from the cadences that are sung, the languages that are used, and the training tools. So your whole time in, from the very beginning, you're socialized where violence is a plausible answer. Now, I would suspect, especially with younger vets transitioning out, has the thought of overcoming that socialization, which people spend a lot of time doing, integral in treating aggression that may be tied to post-traumatic stress? And they've got this socialization plus a mental health aspect plus all these different factors.
Yep. Excellent point. There is some research to suggest that combat exposure, irrespective of PTSD, predicts anger and aggression. So that tells us that part of what you're talking about, just the training process and the experiences, probably does disinhibit anger and aggression, and that makes sense, right? If you're going to be ready to take someone's life, you have to be ready to do that. And so training is one way to facilitate that. And if you look at all the components of that training, there's an intentional step away from empathy. There's kind of there's an objectification of targets, not people, right? And yet we know from working with folks, they come back and no matter what their training was, sometimes they are morally injured. They are horrified by what they did, even if it was quote unquote the right call. If you look at a lot of anger management interventions, those designed specifically for people with trauma histories and also those without, though I think most people with anger, I think many people with anger and aggression have trauma histories. May not be combat, it could be childhood trauma. But empathy, learning how to empathize and consider the perspectives of other people, including the targets of that anger and aggression, is a huge component. And so there has to be a kind of a retraining. I'm always mindful when I do that work with someone, though, in some ways what I'm asking them to do is set aside the anesthesia. And that means there's going to be a period of increased pain because, that numbing, that detachment, the substances, the anger itself, all helps keep at bay those feelings of guilt and regret and remorse. And so as I try to move someone towards empathy and consideration of the outcomes of their behaviors, I'm asking them to do it without anesthesia. It's like we're doing a root canal and no Novocaine, right? So I think before I go there, I put a lot of energy into cultivating skills that will help them manage the feelings that do arise so that they're not overwhelmed, by them. And mindfulness training, and there's some interventions specific to moral injury that I think are really helpful and probably need to be done in coordination with sometimes, before you really get someone to look at the heart of, the impact of their behaviors. These are great comments and questions. Other folks, are there other settings out there or other populations that we haven't spoken to that would be relevant to this discussion? From Chelsea, thoughts on seeking safety? Yeah, so seeking safety is one of the few evidence-based treatments that is designed to simultaneously address substance abuse and PTSD. And it's primarily a present-centered intervention. So I think it's helpful in that it takes into consideration that relationship between PTSD and kind of the self-medication, and teaches good coping skills for both PTSD and things like cravings, you know, that can lead to relapse. The effect sizes for seeking safety aren't huge, but if we go back to looking at the effect sizes for anger and aggression, they're not huge either. In fact, if you look at PTSD compared to other, say, for example, anxiety disorders, it's much harder to treat. It's much more multidimensional, and it doesn't respond as easily or as quickly as some other types of mental health disorders. So I would say, you know, seeking safety is a great tool, and to add it, you know, to your tool belt. And for some folks, you know, it can really jumpstart them on a road to recovery. So I'm for seeking safety, and I'm not aware of any treatment for substance use or anger or suicidality that is kind of a cure-all magic, you know, redo for trauma.
Could you address maybe some of the pitfalls in addressing PTSD in conversation, and that can be more clinical or not? Just what are some identifiable mistakes that people make in the language they use, and what they draw on to try to assist people with this?
Yes. All I have to do is hearken back to my first 5, really 10 years of clinical work. I've learned not to say, I understand, because I don't understand, right? There may be some circumstances where I have life experiences that are similar to, but I don't ever presume that I know what someone else's experience is like, right? I also have learned not to presume that feeling better is someone's primary desire for treatment. Sometimes people, especially when going back to this idea of moral injury, sometimes people feel like their symptoms are part of their way of taking responsibility for some of the things that they've seen or done, you know. And so I think in many, with panic disorder, people come in when they've just got pure panic disorder and all they want is to not have panic, right? It's straightforward. I think PTSD and trauma responses are a little bit more nuanced. There's ways in which people are holding on to something valuable or something that's impactful. That's not to say that they are willing themselves to have PTSD, but it's, you know, there's a way in which their suffering sometimes has meaning. And so I've learned not to just, you know, advertise, let's make you feel better. Let's have you not think about that anymore, or feel better about that thing that happened. Like, instead I will say to people, I don't know if you'll ever feel better about that. But I also want to have you learn how to live a meaningful life. And so maybe there's a way you can live a meaningful life and still carry the memory of what happened. If that makes sense. I could probably go on for days on other mistakes not to make, but
those are a great piece of advice. I think just even generally, not only specific to this conversation, but thank you.
Well, one other that I'll add is, you know, I've learned how to do a lot of these structured evidence-based treatments. And although I'm a big fan and big proponent, I've also had experiences in my own work and in supervising folks where if you get too stuck on the protocol, if you're too busy reading the manual on what you're supposed to be doing for session 3, you'll miss something. I had a intern who was incredibly well trained. She came from a lab of a nationally known PTSD person, and she was plowing her way through the manual, a prolonged exposure manual. And I knew the veteran because he also participated in a group. And he came to me and said, you know, Dr. J, my marriage is falling apart. And I immediately reached out to my intern and said, you know, this is news to me. What's going on? And she said, I don't know. I haven't asked him about his relationship or his marriage, you know. So going back to the idea of social support being one of the huge protective factors, if we don't pay attention to things like risk, changes in risk, or changes in social support, or changes in housing, while we're trying to track down and treat trauma, we can miss the boat. You know, we can be trying to treat trauma while someone is about to lose their housing, and believe me, it's not going to work, or they're about to lose their marriage. Let's see some of these comments. Attuned connection. Can't let clinical knowledge get in the way of a genuine relationship. Amen. Amen. I really like to emphasize that if you're doing this work well, you're bringing yourself into a relationship with someone, which means it's going to hurt if they suffer, and if they lash out, it's going to hurt. And I wouldn't have it any other way. To be attuned means that we as providers are vulnerable. So if we're asking them to do it, we got to do it too. Self-sabotaging behavior and PTSD in a supportive housing setting. I'm not sure I know enough about a supportive housing setting, but I will say that, you know, there are lots of times when I've seen people, especially if they are dealing with their early recovery, or in early, you know, some other kind of structured, I would presume, like a supportive housing setting, highly structured environment, where I've seen people say like, well, you told me on day one that we're going to have to talk about what happened. And so they come into the next session. What I really said is, at some point, we're going to need to talk about what happened. You know, I think it'd be useful. But they come in the very next session in almost kind of a counterphobic way. It's like, I don't want to look, I'm just going to leap. And they just blurt out their trauma. And it's often the last time I see them, or it causes them to relapse, and they'll, if they do come back in, they'll often say like, well, I said what I did what you said, right? And that's not always what was intended. So being really mindful of, you know, kind of expectations of treatment and where people are in the treatment process, I think is helpful. But that's one example of self-sabotage that I've seen. I've also seen people go home to their spouse, like, okay, I need to talk about it. And they go home to their spouses and they tell their spouses about the 3 kids that they killed on their deployment. And now their spouse won't look them in the eye, you know, and it's like, oh, well, so now, you know, yes, it is helpful to talk about it. And, you know, before we talk about who to talk about it with and when to talk about it, let's practice talking about it in the context of therapy a little bit, so that you can rehearse some of these things and they're not so raw coming out. You can be more planful about what you share. I can think of other self-sabotaging things, but let me move on to Paul's comment. How would you recommend non-veteran providers overcome the barrier of veterans not wanting to talk to a non-vet? I see that a lot. Both client and provider get stuck and overcome that. I'm not a veteran, and I have learned in those first 5 years, part of saying I understand why that was problematic, but I've also learned to be really upfront and identify that I'm not a veteran, and so there are things that you're going to, you know, perhaps talk about that I don't have a direct point of reference for. What I can say now, as an old man, and with 20 years of, you know, clinical experiences, I can say I do have the benefit of having talked to thousands of other veterans. And if you're new in your career, you can say, you know, I do have the benefit of talking to other people that have had PTSD or other people that have been in the military. And so I've learned from them, and I'm hoping to learn from you so that I can help other folks, right? I'm really kind of relying on the knowledge that people share with me to help other people that have had those experiences. And I can say this with all sincerity. There's nothing that I've ever offered a veteran that I've worked with that's been useful that hasn't come from another veteran that I've worked with, right? I just see myself as, you know, like I'm the middleman here, right? I'm not the keeper of all knowledge. And I think emphasizing that to folks that are really skeptical can be really important. These are great questions and comments. We've got about 5 more minutes. You can see my email up here. So if people want to back channel me after this discussion, you know, feel free, you know, reach out. I'm happy to continue some of these threads or share the resources if people request them. Any other questions or comments, though, in the last 5 minutes?
I saw your own name listed in some of the research that you provided. Have you researched veterans more specifically? And how did you get into that career?
Yeah, it's diagnostic of narcissism when someone references himself that much. So that's part of it. No, I'm kind of joking. No, in addition to doing clinical work, I've conducted research both in veterans and non-veterans, and usually specific to this idea of PTSD, emotion dysregulation, and one or more high-risk behaviors. So aggression and violence, or suicidality, or substance abuse, and just going back to those few slides on emotion dysregulation. Of all the different features of PTSD, it's when the circuit board fries. It's when they can't process emotions, and this is true of veterans and civilians. That these negative consequences start piling up, and so if we have the chance to do early intervention with that emotion regulation, it's huge. More times than not, we're trying to help them clean up the consequences of that and learn the skills so that the pattern doesn't perpetuate. But yeah, in almost 15 years of research, there's this consistent finding that if people can't identify what they're feeling, if they can't communicate that to other people, or if they can't learn to just sit with it long enough to regulate, something worse than whatever it is that they're feeling will happen. And so teaching them that, and that's where I think mindfulness is powerful, or, some of these other kind of attention to experience. DBT has a lot of mindfulness to it. ACT has a lot of mindfulness to it. And I think that's really important. Other comments or questions? Oh, you bet. Anne or Tom, anything else that you want me to speak to, or anything else that you need to say in closing as we near the hour?
Yeah, I usually end out. My afternoon light has come in or left, so I look like I'm in witness protection in the afternoon. But please, everybody, show your appreciation somehow, whether you're clapping or using a reaction or something. This has been a really, really valuable workshop. So thank you, Dr. Jakubczyk.
Nailed it.
Sorry, I had to say that slow. Just a reminder to everybody, our next workshop is November 16th. So if you have any interest in signing up for it, it is treating traumatic stress considerations with older adults. Also a reminder, I'll send you an email. You'll probably get it before you log off. That has the presentation today, the PowerPoint, and also a link to that first survey that just, give us some feedback on how the workshop went today. And in about a week, I'll give you some time to reflect on what you heard today, and find out from you how you might incorporate that into your work and get some feedback there. So I appreciate you all being here today, and I appreciate the presentation. Dr. J, thank you so much. And Tom, do you have anything that you wanted to say?
As VTSC, we are a King County funded program, as well as we are funded under the WDVA, and all of our trainings that we offer, which is every Friday, are free to you all. Our CEUs are free to you all. So if there's any interest in joining our listserv and getting our monthly newsletters to see what trainings are coming up, I would be happy to get your name on that list. So I will make sure that Anne sends out our information and those email correspondences with you. So, Anne, I think that's it for me.
Okay, good. Thank you all. Have a good afternoon.
See you, everybody.